cardio-oncology really coming as a subspecialty in cardiology. You mentioned that every time, every cycle, we should do a ECG and tropi. And if suppose tropi is slightly raised, will you stop the treatment at that stage only, or they could continue just only ECG and tropi, not an echo?
Help. Yeah, so again, we know that tropi, highly sensitive tropi, has various confounders, and isolated tropi may not necessarily warrant a stoppage of the ICI therapy. You need to again go back and see if there are any other coexisting reasons for the rise in the ICI. Natriuretic peptides, presence of symptoms, and if there is a higher suspicion, then cardiac MRI is the go-to test when you suspect ICI related.
Cardiac MRI is the gold standard in that
Yes.
to take a final decision of stopping. And of course, these are cardiac MRI is proved, then you have to really stop it and reassess after 3 months.
Yes, absolutely.
Dr. Rajesh, regarding the anti-obesity drugs, the semaglutide you mentioned about, it's an injectable form. What's the role of oral, which is, I think, widely available? Will that work, or it's only the injectable semaglutide is recommended? Thank you.
Which oral drug are we?
Travelers you're talking about.
Sorry?
Talking about Travelers actually. You talked about injectable semaglutide.
I think there is no the subcutaneous injections work better than the oral injections because the oral dose, because the side effects with the oral are much more than the subcutaneous. The amount of weight loss which is produced by subcutaneous injections are far superior than the oral.
Dr. Kane, how do you initiate treatment with vericiguat in worsening heart failure? What dose you start? What parameters you monitor? Patient is already on, maybe having CKD with worsening heart failure. And how long to continue? Will it become the fifth pillar in treating congestive heart failure in future?
So it's like this, means whenever a person comes with worsening heart failure, the first thing would be IV diuretics, because worsening is generally because of myocardial dysfunction, which leads to edema and lung edema. So you give IV diuretics, get them out of that failure, and then immediately you can start these drugs 24 hours after stopping IV diuretics.
But
The blood pressure should be at least around 100, and then you start with a small dose of 2.5 milligram, and every 2 weeks you have to increase it to 5 and then 10. So, and then this has to be continued to the best of my understanding. The follow-up with all this, the trial was around 10 months only, but most of the people, I feel, they continue the therapy indefinitely.
so it will be the fifth pillar in
It will
treatment
be
of
the
heart
fifth
failure?
pillar, yes, yes, yes.
No, I think Dr. S.B. Gupta asked a very relevant question, Rajesh. Because what we are using in India is Rybelsus, which is an oral form. And what was done in SELECT trial was semaglutide, Ozempic, which is injectable. So whether we can translate the same benefit of injectable to oral, that's a question. And earlier in diabetic, this was non-diabetic, SELECT. But in diabetic population, the SUSTAIN was successful. But when the same attempt was done with Pioneer 6, with oral semaglutide, that didn't show the the same amount of benefit. So when in diabetic population, there was no direct translation of the benefit of the injectable to oral. Dr. Gupta's question is, can we extrapolate this SELECT trials benefit of injectable Ozempic to our oral Rybelsus? In India, we have oral Rybelsus, and people are spending about 12,000 rupees, 10,000 rupees a month. And that also we are not giving the full trial dose. So are we justified in causing the cost of 10, 12,000 when we are in the diabetic subgroup, we had not seen the same amount of benefit? So I think this was a very relevant comment by Dr. Gupta.
No, I agree with you. I don't know whether subcutaneous preparation is available in India. Yeah,
It's
so
not
in the
available at the
United
moment,
States of
not available.
America, you know, they're using subcutaneous injections. Oral is rarely used.
Right, only the advantage of injectable is the GI side effects are reduced some
That's
extent.
right, tremendously,
the only thing.
because you
Otherwise,
have-
I think the mechanism GLP both, weight reduction comes with both, so inflammatory markers come down. So all those benefits of cardiovascular we are going to definitely should get with oral. There is no large trial with the oral semaglutide like injectable he has got. But as a logically think the same mechanism, inflammation, marker, weight reduction, everything. Not only the cardiovascular, I think the sleep apnea, osteoarthritis, fertility, there are so many benefits now coming up with a semaglutide. not only the cardiovascular part.
No, I think it's a utility, the compliance, which is very important, and that's why subcutaneous has come over as compared to oral. The compliance is not adhered to because of the GI side effects with oral semi.
That it has taken the bariatric surgery out of market with much extent, that whole thing.
It was all lectures were excellent. I just would like to add, like ICI myocarditis is a very important topic today we had discussed. As we know that, but in that case, because I started the cardio-onco department at Tata Memorial for last 5 years, we are doing every year we are submitting the registry in a global international cardio-oncology. The early ICI myocarditis is very important because most of the time it is very difficult to pick. In that cases, CMR may or may not. So in that cases, we are now having an advantage of having a DOTA scan, the nuclear medicine, to pick up the myocarditis. And then if we initiate and temporarily hold the therapy and restart once the patient recovered, it's a combined call. But it was really early myocarditis, I would like to say. It is very difficult to pick up clinically. Yeah. Yeah.
Even the studies that
Yeah.
that I reviewed, MRI also sensitivity is around 30 to 75%.
Yes,
So it's
yeah,
not 100%.
yeah.
And also the timing of doing the MRI, because LG usually comes 4 days after establishing, after myocarditis sets
Yeah.
in.
So then the
point is-
treating medical oncologists are in confusion whether to
Yes.
stop, withhold, or continue
Right.
in advanced cases. Yeah.
Very valid
Yeah,
point.
yeah.
The last question by Bhavesh, I think, Arivle.
Right. So with the recent FDA approval for semaglutide for the benefits of reducing cardiovascular events in obese patients, so do we have some kind of guidelines where we can say at this BMI, if the patient has high cardiovascular risk, then it's better to start semaglutide? And is there something like that?
Well, I think 30 kilograms per meter square without comorbid states and 27 kilogram per meter square with comorbid states. You know, if you have this BMI and if the patient is adhering to his diet and his lifestyle, in spite of that the weight is not coming down, then you start anti-obesity. So 30 and 27, 27 with comorbid states, 30 without comorbid states, and he's gone through all the diet and he's gone through all the lifestyle modifications. And that's a time where it's not coming down, and then you roll on to the anti-obesity drugs. That's how the guidelines say. Yeah.
So thank you very much, all my colleagues, and we move on to the next. Thank you.